The Memphis and Shelby County Medical Society maintains its historical membership records in a wood-paneled library on Union Avenue, where leather-bound ledgers document every physician licensed to practice in the city from 1880 forward, preserving the names and credentials of doctors who shaped healthcare in the Mid-South across generations of medical advancement and institutional development. A medical historian named Dr. Sarah Chen discovered an impossible contradiction in those records during the fall of 2018 while researching the evolution of public health practice in Memphis during the 1920s, finding extensive documentation that identified Dr. Jonathan Abraham Sterling as the city's most prominent physician, specializing in infectious disease treatment between 1922 and 1929, with newspaper articles praising his innovative approaches to controlling yellow fever outbreaks, with hospital records showing him performing hundreds of successful surgeries, with public health reports crediting him with reducing infant mortality in Memphis's poorest neighborhoods by nearly 40% during his 7 years of documented practice. The archival evidence presented Sterling as a medical pioneer, whose work had saved countless lives during a crucial period when Memphis struggled with epidemic disease and inadequate healthcare infrastructure. Yet when Sarah attempted to verify his credentials through medical school records, state licensing databases, and professional certification archives, she discovered that no Jonathan Abraham Sterling had ever graduated from any American medical school, had never been issued a Tennessee medical license, and appeared in no documentation beyond Memphis's own institutional records describing his supposedly extraordinary medical career. The absence of credentials for someone who had practiced medicine at the highest levels of Memphis healthcare would be troubling under any circumstances, but became impossible when Sarah discovered that Sterling had supposedly served as chief of medicine at Memphis General Hospital from 1924 to 1927, had testified as an expert witness in multiple court cases requiring medical expertise, had published articles in regional medical journals about infectious disease treatment protocols, and had been appointed to the city's Board of Health in 1926, all positions and activities that should have required verification of medical training and licensure that Memphis institutions apparently never obtained, or that were satisfied through documentation that has since vanished from every archive that should have preserved it. Hospital administrator files showed Sterling being hired with appropriate credentials verification noted, yet the actual diplomas, transcripts, and license certificates that should have been reviewed during that verification process existed nowhere in the extensive records that Memphis General maintained about its medical staff across more than a century of operation. The Medical Society's membership rolls listed Sterling with full professional standing from 1922 through 1929, indicating he had satisfied all requirements for recognition as a legitimate physician, yet the Society's own files contained no copies of the educational or licensing documents that membership supposedly required, leaving only notations that proper credentials had been verified by committees, whose members had all died decades before. Sarah began asking questions about what evidence they had actually examined. The mystery deepened when Sarah expanded her search beyond Memphis to examine medical school graduation records from every institution in the United States that operated during the period when Sterling would have completed his training, finding that no one with that name had graduated from Johns Hopkins, Harvard, Yale, the University of Pennsylvania, or any of the other elite medical schools whose degrees would have provided the credentials necessary for someone to achieve Sterling's level of professional prominence in Memphis during the 1920s. She broadened the search to include every medical school in the South, examining records from Tulane, Vanderbilt, Meharry, and dozens of smaller institutions that trained physicians during the early 20th century, discovering that while several men named Sterling had graduated from various programs during the relevant period, none carried the first names Jonathan Abraham, and none matched the biographical details that Memphis records provided about their celebrated infectious disease specialist. The documentary void extended internationally, with no Jonathan Abraham Sterling appearing in records of American students who had studied medicine in Europe during the years before World War I, when some wealthy families sent their sons abroad for training that carried particular prestige, suggesting that wherever Sterling had actually acquired his medical knowledge and skills, it had not been through the conventional channels that produced licensed physicians in early 20th century America. Subscribe now because the evidence we're presenting reveals that this impossible doctor was part of a clandestine network providing sophisticated medical care to Memphis's African American community during an era when racist hospital policies and medical segregation meant that black residents either received no health care at all or were treated in grossly inferior facilities by physicians who saw them as subjects for experimentation rather than as patients deserving competent and compassionate treatment. Memphis occupies a strategic position on the Mississippi River, where the borders of Tennessee, Arkansas, and Mississippi converge, creating a city whose economy and culture have always been shaped by the cotton trade that made the region wealthy through enslaved labor, and by the geographic centrality that positioned Memphis as a transportation hub connecting the Deep South to national markets and northern cities. The downtown district spreads back from the river bluffs where cotton warehouses once dominated the commercial landscape, where Beale Street developed as the center of African-American business and cultural life despite constant pressure from white authorities who wanted to control or destroy black economic independence. The city maintains deeply contradictory relationships with its past, celebrating its role in the birth of blues music and its contributions to American popular culture, while remaining profoundly uncomfortable with honest examination of the racial violence that characterized Memphis throughout the period when white civic leaders were building the institutions and accumulating the wealth they now tout as evidence of the city's historical significance and regional leadership. The 1920s represented a particularly brutal period for African Americans in Memphis, with the resurgence of the Ku Klux Klan achieving political influence that extended into city government and law enforcement, with lynchings and racial terrorism remaining threats that shaped every aspect of black life and limited what people could safely say or do, without inviting violent retaliation from white supremacists who saw any assertion of equality or dignity as challenges to the racial hierarchy that segregation was designed to maintain. Healthcare existed as one of many domains where this hierarchy manifested in deadly forms, with Memphis hospitals maintaining strict segregation that relegated African American patients to basement wards with antiquated equipment and minimal staffing, with white physicians who treated black patients often doing so primarily to gain surgical experience or to test experimental treatments they wouldn't risk on white people, with medical schools using black bodies for training and research without consent or compensation, while denying African Americans opportunities to become physicians themselves, except at the single historically black medical school, Meharry Medical College in Nashville, whose graduates faced enormous barriers to practicing in cities like Memphis, where white medical societies refused them membership and white-controlled hospitals denied them admitting privileges. This healthcare apartheid created desperate conditions in Memphis's African American community, where residents suffered from higher rates of infectious disease, maternal mortality, infant death, and untreated chronic conditions than white populations, but had extremely limited access to competent medical care that might address their needs, with most black families relying on traditional healers, midwives, and folk medicine because professional health care remained either completely unavailable or provided only through segregated facilities that delivered such poor quality treatment that many people reasonably feared hospitals as places where they would die rather than recover from their illnesses. The few African American physicians who managed to establish practices in Memphis during the 1920s faced constant harassment from white medical societies that questioned their credentials and competence regardless of their actual training, with authorities deploying licensing requirements and professional regulations as weapons to limit black medical practice and to prevent African American doctors from achieving economic success that might challenge assumptions about racial hierarchies and black intellectual capacity. Against this oppressive backdrop, the appearance of someone like Dr. Jonathan Abraham Sterling, who supposedly achieved extraordinary prominence in Memphis medicine, while leaving no trace in the credentialing systems that controlled access to medical practice, suggested something far more complex than simple fraudulent impersonation by someone pretending to have training they lacked. Because Sterling's documented medical work demonstrated genuine expertise that couldn't be faked, and that produced measurably positive health outcomes in communities where he worked, indicating that whoever occupied that identity possessed real medical knowledge and skills even if they had acquired them through unconventional means that left no traces in the official archives of American medical education. The pattern implied a sophisticated strategy, rather than simple deception, a conscious decision to create a physician identity that could navigate Memphis's segregated medical establishment while actually serving the African American community that white healthcare institutions systematically neglected and abused. Sarah's investigation into the specific context where Dr. Sterling's name appeared in Memphis records revealed a pattern where his documented activities concentrated almost exclusively in North Memphis and Orange Mound, the city's largest African-American neighborhoods, where his practice supposedly focused on infectious disease treatment and public health interventions that addressed exactly the conditions that killed Memphis's black residents at rates far exceeding white mortality from the same causes. A 1923 newspaper article described Sterling's innovative approach to treating yellow fever, which involved aggressive mosquito control in affected neighborhoods, combined with isolation protocols that prevented disease transmission while ensuring patients received supportive care that improved survival rates, methods that proved remarkably effective in reducing Memphis's annual yellow fever outbreaks that had previously killed dozens of residents every summer, and that disproportionately affected African Americans living in areas with poor sanitation and inadequate drainage. His documented work during the 1925 typhoid epidemic showed similarly focused attention on Memphis's black community, with public health reports crediting him with establishing temporary treatment centers in churches and community halls that brought medical care directly to neighborhoods where residents lacked transportation to reach hospitals that would have relegated them to basement wards regardless, and where bringing sick family members meant exposing them to the additional dangers of hospital-acquired infections and medical experimentation disguised as treatment. The treatment centers provided clean water, basic sanitation, fever reduction, and supportive care that allowed many typhoid patients to recover at home under supervision, rather than dying either from the disease itself or from the complications of hospitalization in facilities that saw black patients as disposable subjects rather than as human beings deserving competent medical attention and respect. Sterling's hospital work at Memphis General, where records showed him serving as chief of medicine from 1924 to 1927, concentrated in the segregated wards where African American patients received care, with surgical logs indicating he performed hundreds of procedures that white surgeons typically avoided because they involved black patients whose deaths wouldn't generate the kind of scrutiny or professional consequences that would follow from poor outcomes in white patients, meaning the segregated wards functioned as training grounds where less experienced physicians practiced techniques they would later deploy when treating white people whose lives the medical establishment actually valued. Sterling's surgical success rates appeared significantly higher than those of other physicians working in the segregated wards, suggesting he possessed genuine surgical skill, and that he approached black patients with the same care and attention that competent physicians provided to white patients, rather than treating them as expendable practice subjects whose suffering and death mattered less than the educational opportunities their bodies provided. The question of who Jonathan Abraham Sterling actually was and how he had acquired medical expertise sufficient to achieve documented success in treating infectious disease and performing complex surgery led Sarah to examine whether he might have been an African-American physician who had obtained training at Meharry Medical College or at one of the few other institutions that educated black doctors during the early 20th century, but who had created a new identity to circumvent the barriers that Memphis's white medical establishment erected against African-American physicians regardless of their credentials or competence. This interpretation would explain both his genuine medical capabilities and his lack of documentation in conventional credentialing systems, because a black physician practicing under an assumed white identity would need to avoid any verification processes that might reveal his actual background and racial classification, relying instead on demonstrated competence and on sympathetic white colleagues who were willing to provide cover for someone whose work served important public health purposes, even if his presence in Memphis medicine involved deception about fundamental aspects of his identity. The racial passing hypothesis gained support when Sarah discovered that several of Sterling's documented colleagues at Memphis General were known to hold relatively progressive views about racial equality and medical access, with one senior physician, Dr. William Harrison Foster, having publicly criticized segregated hospital wards and having argued in medical society meetings that competent African-American physicians should be granted hospital privileges regardless of racial policies that typically excluded them, positions that had generated controversy and that had damaged Foster's standing among conservative colleagues who saw any challenge to medical segregation as betrayal of Southern traditions and white solidarity. Foster's willingness to advocate for integration despite professional costs suggested he might have been sympathetic enough to actively assist an African-American physician who was attempting to practice under an assumed white identity, providing the institutional support and credibility that would have been necessary for someone without conventional credentials to achieve the level of prominence that Sterling's records documented. Sarah's examination of Foster's personal papers, preserved at the University of Tennessee Medical Library, revealed correspondence that obliquely referenced his work with someone he described only as our mutual friend concerned with public health in the colored wards, using language that suggested a relationship requiring discretion and that avoided creating explicit documentary evidence about the nature of their collaboration or about the friend's actual identity and credentials. Exactly the kind of carefully ambiguous communication that might characterize a relationship between a white physician, providing institutional cover, and a black physician practicing under false identity to circumvent racist barriers to medical practice. Several letters discussed coordinating approaches to infectious disease treatment in Memphis's African-American neighborhoods, with Foster seeking advice about protocols that his unnamed friend had apparently developed through direct experience treating patients in conditions that white physicians typically avoided, suggesting genuine medical expertise that commanded Foster's respect, even as the relationship required maintaining strategic ambiguity about who was actually providing the knowledge and performing the work being discussed. The investigation took a significant turn when Sarah located the daughter of a woman who had worked as a nurse in Memphis General's segregated wards during the 1920s, finding that the elderly woman retained remarkably clear memories of her mother's stories about the mysterious doctor. Sterling, who had treated African-American patients with unusual care and competence during a period when most white physicians approached the segregated wards as opportunities for practicing procedures, they wouldn't risk attempting on white patients whose deaths might generate professional consequences or legal liability. The nurse had apparently understood that Sterling was not what he appeared to be, that his presence in the hospital served purposes beyond conventional medical practice, though she had never explicitly stated what she suspected about his true identity or his actual relationship to the African-American community, whose health outcomes improved dramatically during the years when he worked in the segregated wards, treating conditions that other physicians considered hopeless or unworthy of serious medical attention. The daughter recalled her mother describing how Sterling would arrive at the hospital before dawn to check on African-American patients who had undergone surgery the previous day, ensuring they received adequate pain medication and that their post-operative care met standards typically reserved for white patients, rather than the minimal attention that segregated ward patients usually received from nursing staff who shared the broader society's devaluation of black lives and suffering. He would stay late into the evening consulting with families about home care for patients being discharged, providing detailed instructions, and ensuring that people understood medication regimens and warning signs that might indicate complications requiring return to the hospital, demonstrating the kind of patient education and follow-up that characterized good medical practice, but that African-American patients rarely experienced from physicians who saw them as inferior beings, unworthy of the time and attention that respectful care required. The nurse had told her daughter that Sterling spoke with particular knowledge about the challenges facing Memphis's black community, understanding in ways that white physicians typically didn't the economic constraints that prevented people from seeking medical care until conditions became dire, the mistrust of hospitals and doctors that arose from histories of abuse and experimentation, the importance of working with traditional healers and community leaders to ensure that medical interventions would be accepted and followed, rather than rejected, as impositions from a white medical establishment that had proven itself hostile to African-American well-being, all suggesting either extraordinarily empathetic cross-racial understanding or alternatively insider knowledge that would be expected from someone who was actually part of the African-American community, regardless of how he appeared or what identity he presented when moving through Memphis's segregated professional spaces. Sarah's research into Meharry Medical College records from the relevant period revealed several graduates whose subsequent careers couldn't be traced through conventional medical directories and licensing databases, suggesting they might have practiced under circumstances that required avoiding the documentation systems that typically tracked physicians throughout their careers. Though none of the missing graduates matched the sparse biographical details that Memphis records provided about Jonathan Abraham Sterling, complicating efforts to identify who might have occupied that identity during the 7 years when it appeared prominently in the city's medical landscape. The pattern of untraceable Meharry graduates raised broader questions about how many African American physicians during the segregation era might have practiced under assumed identities, or in ways that deliberately avoided creating the kind of documentary traces that would make them visible to hostile white medical societies and licensing boards that used credentialing requirements as weapons to limit black medical practice and to prevent African American doctors from achieving professional success that might challenge racist assumptions about intellectual capacity and competence. The financial aspects of Sterling's practice provided additional clues about his actual identity and purposes, with records indicating that while he maintained a private practice that theoretically served any Memphis residents who could pay his fees, his actual patient base consisted almost entirely of African Americans, many of whom could afford minimal compensation for his services, suggesting that generating income was not his primary motivation, and that he was either independently wealthy or supported by some source of funding that allowed him to practice medicine according to principles of need rather than ability to pay. Hospital records showed him donating significant amounts of medical supplies to the segregated wards, purchasing equipment and medications that the hospital administration refused to allocate for African American patients, despite providing abundant resources for wards serving white people, demonstrating both financial capacity and commitment to ensuring that black patients received care comparable to what white patients could expect from Memphis's healthcare institutions. The pattern suggested someone whose actual circumstances allowed him to focus on medical practice as social justice work rather than as conventional professional employment aimed at accumulating wealth and status, aligning with how African American physicians, who had achieved rare economic success through inheritance or business ventures, sometimes used their resources to provide health care to communities that white medicine systematically neglected, accepting minimal payment or working entirely without compensation, because they understood that serving their community's desperate medical needs mattered more than personal financial gain, and because their economic security didn't depend on income from medical practice that could never generate significant revenue when most potential patients lived in poverty, that made paying for health care impossible regardless of how desperately they needed treatment. Sarah's examination of Memphis property records from the 1920s revealed that someone matching Sterling's name had purchased a substantial house in a transitional neighborhood where both white and black residents lived in proximity that would become increasingly rare as Memphis's residential segregation intensified during subsequent decades, suggesting he might have deliberately chosen a location that allowed some ambiguity about his racial identity and social positioning in ways that would have been impossible in either exclusively white or exclusively black neighborhoods where his presence would have required explanation, and where maintaining dual identity across racial lines would have been essentially impossible without constant risk of exposure. The house sat near the boundary between what would become rigidly segregated zones, positioning its occupant in space that mirrored the social ambiguity that his professional identity apparently required, allowing movement between white and black worlds in ways that strictly segregated geography would have prevented. The property's ownership transferred in 1929 to an unidentified buyer, whose name appeared nowhere else in Memphis records, coinciding exactly with the end of Sterling's documented medical practice and his disappearance from all archival sources, suggesting coordinated exit from both his professional identity and his residential presence in Memphis that allowed whoever had occupied the Sterling role to vanish completely when circumstances made continuing the deception inadvisable or when the purposes it served had been accomplished or had become achievable through other means. The timing aligned with broader changes in Memphis's medical landscape, including the opening of a new hospital specifically serving African American patients, which, while still segregated and inferior to facilities for white people, nevertheless represented improvement over the basement wards of Memphis General, and which might have reduced the desperate need for someone like Sterling, who had provided competent medical care to black patients within an institutional structure that otherwise treated them as expendable experimental subjects. The new hospital, Collins Chapel Colored Hospital, employed several African American physicians who could finally practice with some institutional support rather than working entirely independently against the coordinated opposition of white medical societies and hospital administrators, creating opportunities for legitimate black medical practice that reduced though certainly didn't eliminate the barriers that had made Sterling's phantom identity potentially necessary during the earlier and more oppressive period, when African American doctors faced nearly insurmountable obstacles to practicing in Memphis, regardless of their training or competence. The improved, though still grossly inadequate medical infrastructure for Black communities might have allowed whoever had been Sterling to retire that identity and either leave Memphis entirely or to practice under his actual name and credentials if he had indeed been an African American physician who had operated under false identity during the years when that deception provided the only viable path to serving his community's healthcare needs. Sarah's investigation revealed that Memphis's medical community during the late 1920s had experienced significant controversy about Sterling's practice, with some white physicians questioning his credentials and demanding that the medical society investigate whether he had actually obtained proper training and licensure, or whether he had somehow fraudulently established himself in Memphis medicine without satisfying the requirements that supposedly applied to all practitioners regardless of their effectiveness or the outcomes they achieved with patients. The challenges appeared motivated less by genuine concern about credentials than by resentment that Sterling had achieved professional success while focusing his practice on African American patients, violating the unwritten rules that physicians who worked primarily with Black people should be marginal figures in the medical community, rather than respected colleagues who sat on the Board of Health and who testified as expert witnesses in important legal cases. The medical society had apparently initiated some form of credential review in early 1929, though records of that investigation were conspicuously absent from the society's archives, despite the organization's otherwise meticulous documentation of its proceedings and actions across more than a century of institutional history, suggesting that whatever the review discovered had been deliberately suppressed, either because it exposed Sterling as having fraudulent credentials, which would have embarrassed the hospitals and institutions that had employed him, or because it revealed something even more troubling about the nature of his practice and identity, that Memphis's white medical establishment preferred to erase from memory rather than acknowledge publicly. Sterling's abrupt disappearance from all Memphis records immediately following the initiation of this review strongly suggested that he had recognized that exposure was imminent and that continuing his practice under that identity had become untenable once hostile physicians had decided to investigate his background with determination to find evidence they could use to destroy his professional standing. The question of what happened to Jonathan Abraham Sterling after 1929 led Sarah to examine medical practice records from other southern cities during the early 1930s, looking for patterns of prominent physicians with questionable credentials who appeared suddenly in communities with large African American populations desperately needing competent health care, wondering whether the same individual or perhaps a network of Black physicians might have employed similar identity strategies in multiple locations, moving when exposure threatened, and re-establishing practice under new names in new cities, where the same desperate conditions created both need for their services and opportunity for them to operate before hostile white medical societies could organize effective opposition. She found suggestive patterns in Birmingham, Atlanta, and New Orleans, where physicians with documented expertise in infectious disease treatment and public health had appeared in medical records during the 1930s and 1940s without clear credentials verification, practicing primarily in African American communities, achieving significant positive health outcomes, and then disappearing from records when questions about their backgrounds began to surface. The pattern suggested a deliberate strategy that multiple Black physicians might have employed across different southern cities, using assumed identities to circumvent racist barriers to medical practice while serving desperately underserved African American communities, remaining in each location only as long as they could maintain their cover, and moving on before exposure would destroy not just their current practice, but potentially their entire ability to continue providing medical care, regardless of where they attempted to establish themselves. This itinerant approach to medical practice would have required extraordinary courage and commitment, accepting professional instability and constant risk of exposure in exchange for the ability to provide competent health care to communities that white medicine systematically neglected, choosing to serve people who desperately needed their skills over the professional security and social standing that came with conventional medical careers that required accepting segregation's barriers and limiting one's practice to whatever opportunities white-controlled institutions permitted African American physicians to pursue. The broader implications of Sterling's phantom practice extended beyond individual deception to reveal systematic failures in Memphis's healthcare system that created conditions where fraudulent credentials might actually serve public health better than legitimate practice by physicians who possessed proper training but who approached African American patients with the racist assumptions and experimental attitudes that characterized much of Southern medicine during the segregation era, raising profound questions about the relationship between formal credentialing and actual competence and about whose interests licensing requirements actually served when they functioned primarily to maintain racial hierarchies rather than to protect patients from harmful or incompetent medical treatment. Sterling's documented success in reducing infectious disease mortality and improving surgical outcomes in Memphis's African American community suggested that his medical knowledge and skills exceeded those of many properly credentialed white physicians who worked in the segregated wards, forcing recognition that the credentialing systems that granted some people authority to practice medicine while excluding others were themselves implicated in perpetuating the healthcare disparities that killed Black patients at rates that should have generated professional scandal, but that white medical societies treated as natural and unremarkable consequences of supposed racial differences in health and constitution. Sarah's research into public health outcomes in Memphis during the 1920s confirmed that African American mortality rates from infectious disease had indeed declined significantly during the period when Sterling practiced in the city, with particularly dramatic improvements in neighborhoods where his documented activities concentrated most heavily, suggesting that his work had genuine epidemiological impact that extended beyond individual patient care to affect community-wide health status in ways that conventional white medical practice had consistently failed to achieve, despite supposedly superior credentials and institutional resources. The correlation between Sterling's presence and improved health outcomes in Black neighborhoods raised uncomfortable questions about how many lives might have been saved if Memphis's medical establishment had focused on serving African American communities with the same competence and dedication that Sterling had demonstrated, rather than maintaining segregated healthcare systems designed primarily to reinforce racial hierarchies and to provide white physicians with experimental subjects rather than to deliver effective treatment to all residents regardless of their race. The economic analysis of what Memphis's African American community had lost when Sterling disappeared from medical practice in 1929 revealed both the tangible impact of his work and the broader costs of medical segregation that made his phantom practice necessary in the first place, with researchers estimating that the return to previous mortality patterns in neighborhoods where he had worked most intensively resulted in hundreds of preventable deaths during the 1930s, as infectious disease rates climbed back toward the levels that had prevailed before his arrival, demonstrating that whatever his actual identity and credentials, his medical practice had served essential public health functions that no other physician in Memphis had been willing or able to fulfill during the crucial years when his presence made measurable difference in whether African American residents survived diseases that proper medical attention could successfully treat. The contemporary Memphis medical community showed no interest in investigating the Jonathan Abraham Sterling mystery, or in acknowledging that one of the city's most effective physicians during the 1920s had apparently practiced without legitimate credentials, with current medical society leadership dismissing questions about historical credentialing as irrelevant to modern healthcare and suggesting that focusing on a potentially fraudulent physician from nearly a century earlier served no useful purpose and might damage Memphis medicine's reputation by drawing attention to irregularities in how the profession had operated during earlier periods. This institutional resistance to examining its own complicated past paralleled broader patterns where American medical establishments resist honest accounting of how segregation-era healthcare systematically harmed African American patients, and of how the credentialing and licensing systems that supposedly ensured quality actually functioned, primarily to maintain racial hierarchies that had nothing to do with medical competence and everything to do with preserving white professional dominance. The archives containing Jonathan Abraham Sterling's medical records remain accessible to researchers at Memphis institutions that hold them, though the files themselves reveal remarkably little about who actually occupied that identity during his 7 years of documented practice, or what became of him after he vanished from Memphis medicine. in 1929, preserving instead the careful documentation of his professional activities without providing the biographical details or credential verification that would enable Sarah or other investigators to connect the phantom physician to an actual person whose life before and after his Memphis practice could be traced through normal genealogical and professional records. The files create an official history of medical practice without revealing who practiced medicine, describe healthcare delivery without identifying who delivered care, document professional success without explaining how someone without conventional training achieved the medical expertise that his outcomes demonstrated, leaving researchers to recognize that sometimes institutional archives preserve the results of resistance strategies while obscuring the strategies themselves and the people who employed them. What remains in Memphis medical archives is a name appearing across hundreds of documents, describing 7 years of innovative public health work and competent medical practice that saved lives in African American communities, where white healthcare institutions delivered either grossly inadequate treatment or actively harmful experimental medicine disguised as care, documenting a physician who possessed genuine expertise regardless of how he acquired it, and who demonstrated commitment to serving desperately underserved populations, regardless of the professional risks that such work apparently entailed, creating a record that simultaneously confirms his medical impact and conceals his actual identity in ways that suggest the concealment itself might have been necessary for his practice to occur at all, during an era when racist credentialing systems and medical segregation meant that African American physicians faced nearly insurmountable barriers to providing the healthcare that their communities desperately needed. The phantom physician exists in Memphis's documentary record as evidence of both extraordinary individual dedication and systematic institutional failure, marking someone who circumvented unjust barriers to serve communities that white medicine systematically neglected, while simultaneously revealing how thoroughly racism corrupted American healthcare during the segregation era, when licensing requirements functioned primarily to maintain racial hierarchies rather than to protect patients from incompetent practice, and when the most credentialed physicians often delivered the worst care to the patients who needed competent treatment most desperately, forcing recognition that the relationship between formal credentials and actual medical competence was far more complicated than professional mythology suggested, and that sometimes the people best equipped to serve particular communities were exactly those whom credentialing systems worked hardest to exclude from medical practice. Sarah's inability to definitively identify who Jonathan Abraham Sterling actually was, or to trace what happened to him after 1929, reflects both the success of whatever identity protection strategies he employed and the broader erasure of African American medical history from institutional archives that preserved extensive documentation about white physicians while treating black doctors' contributions as marginal and unworthy of the careful record-keeping that characterized how medical societies documented their preferred narratives about professional development and institutional history, creating gaps in the historical record that make recovering the full truth about segregation-era healthcare essentially impossible, despite the evidence that survives in fragments suggesting that reality was considerably more complex than sanitized official histories acknowledge. The Jonathan Abraham Sterling story persists as one of those fragments, a partial record of resistance to medical segregation that achieved measurable success in improving African American health outcomes while operating through deception that was apparently necessary for the work to occur at all, preserved in archives that document his impact without revealing his identity, that confirm his medical competence without explaining his training, that demonstrate his commitment to serving Memphis's black community without clarifying whether he was himself African American practicing under false identity, or was perhaps a white physician whose dedication to racial justice led him to focus his medical career on populations that his colleagues systematically neglected and abused, leaving contemporary researchers with a mystery that may never be fully solved because the successful circumvention of unjust systems requires exactly the kind of identity protection and documentary ambiguity that makes historical recovery extremely difficult or impossible. Memphis continues to struggle with healthcare disparities that disproportionately harm African American residents nearly a century after Jonathan Abraham Sterling demonstrated that competent medical practice combined with genuine commitment to serving black communities could achieve dramatic improvements in health outcomes. suggesting that the systemic racism he apparently circumvented through his phantom practice persists in evolved forms that continue to produce the same unjust patterns of differential mortality and morbidity across racial lines, making his story not simply historical curiosity, but rather reminder of how long American medicine has failed African American patients and how far the profession still has to go before it can claim to provide truly equitable health care to all people regardless of race. The phantom physician achieved more in 7 years of practice without credentials than many properly licensed doctors accomplished across entire careers, forcing difficult questions about what credentials actually signify and whose interests they actually serve when licensing systems function primarily to maintain professional hierarchies, rather than to ensure that medical knowledge and skill reach the communities that need them most desperately. Subscribe now so you won't miss our next investigation into American medicine, where the official records preserve traces of physicians who circumvented racist systems to deliver competent health care to communities that white medical establishments systematically neglected, leaving behind mysteries that challenge everything we assume about the relationship between credentials and competence and about who really served patients best during the brutal decades when segregation corrupted every aspect of American professional life.